Good afternoon. I am Katrina Hoff. I'm the director of the Southwest Idaho Area Health Education Center, and we are really pleased to have Dr. Isabella Farina with us today presenting outpatient COPD management. I have pasted some information in the chat that has to do with the disclosure. No one involved in planning or presenting this activity has any relevant financial relationships to disclose, and the attendance code, should you need it, to go in and complete the post-session evaluation. You'll also get an email with the evaluation link and information. And this really helps us. Your feedback is important to us and helps us improve. And with that, I'm going to hand it over to Dr. Farina to continue to present sorry, I got a little flustered. COPD management. Thank you.
All right, thanks so much, Katrina. So we'll get started here. These are the objectives for the next 45 minutes. Would like to review the updated recommendations for both pharmacologic and non-pharmacologic outpatient treatments of COPD. Understand the research and evidence behind these updated recommendations, and then practice implementing a comprehensive approach to COPD management. And so, as we do with a lot of things, I would want us to kind of zoom in on a case presentation. And so, we have the case of a 70-year-old man who is part of your outpatient clinic. He is following up after having a COPD exacerbation that was treated outpatient about 2 weeks ago. He, in addition to his COPD, has high blood pressure, high cholesterol, GERD. He currently takes Symbicort, lisinopril, atorvastatin, and omeprazole for these conditions. He is married and is the primary caretaker of his wife, who has become more homebound, which has led to some stress for him, which he increased his smoking recently to a half pack a day from quarter pack a day. And so kind of keeping this patient in the back of our mind as we walk through our comprehensive treatment strategy, and we'll circle back to practice, what updated recommendations we'd have for him at this theoretical office visit. So then kind of zooming out a little bit, why do we care about COPD? Why spend the next 45 minutes talking about it? As I think a lot of us know, COPD is a very common medical condition treated in the primary care setting. In 2021, it was estimated that about 6.5% of the US population, which is about 14.2 million at that time, reported having COPD. It accounts for most of the deaths from chronic lower respiratory disease, and is the 6th leading cause of death in the United States as of 2021. And then it does tend to have an elevated prevalence in women, older adults, ages 65 and older, rural residents, adults with lower education levels, and those who have ever smoked. And I think highlighting that in Idaho, we have a lot of rural practitioners, and so it's not uncommon for primary care docs and primary care clinics to be the really integral part of someone's COPD management if they especially don't have access to a specialist care close by. Then we have a brief history of COPD. I'd never really read about it before or thought about how long COPD has been a diagnosis that we are familiar with, but back in the 1600s, a Swiss physician, Théophile Bonnet, referred to a patient with voluminous lungs. And later in the 1800s, the same person that invented the stethoscope distinguished chronic bronchitis from asthma, which we still to this day have that distinction between those two disease states. While there is overlap, they are thought to be distinct. And it wasn't until the 1950s, which is like so recent, that researchers began to recognize that smoking can be a leading cause of chronic bronchitis and emphysema. And it wasn't until 1977 that the Global Initiative for Chronic Obstructive Lung Disease, or GOLD Foundation, launched and began providing standardized guidelines for diagnosis and management of COPD. And the GOLD Foundation is a collaboration between the National Heart, Lung, and Blood Institute, the NIH, and the WHO. So it is both US and international guidance and expertise. And we have their little logo here. And so this presentation itself is going to kind of narrow in on the outpatient management of stable COPD, and we will not have time to review the diagnosis based on symptoms or spirometry. We will instead think of an already established patient who carries the diagnosis of COPD and what we can do for them in our primary care setting. And we will also not review specialist treatments of COPD. So this includes surgical or bronchoscopic interventions. It's just out of the scope of what a primary care office would be doing for our folks. And really, the GOLD 2025 guidelines are going to provide the majority of the roadmap for this presentation, but we will highlight some of the actual research behind the recommendations. And I should mention, at any point, if there's like a burning question, you guys can ask mid-presentation, but there should be time at the end of the presentation for questions as well. All right, so looking broadly, when we have someone with COPD, our diagnosis, as I mentioned, is based on patients' symptoms, their spirometry evaluation, and their risk factors, namely smoking, and as well as genetic components that can increase people's risk of COPD. Let me just see if there's anything in the front. Okay, perfect. Then there is, once someone has gained a official diagnosis of COPD, there's often initial management that we think about, like where to start with their both pharmacologic and non-pharmacologic therapies. And I kind of highlighted this initial management so we can see smoking cessation being a huge part of both the prevention and management of COPD, routine vaccinations, activity and lifestyle modification, those initial inhaler therapies, and then self-management education. So thinking about how to make sure you're using the medications you have correctly, that you are modifying your risk factors, that you're able to behaviorally control breathlessness. And GOLD actually includes a written action plan as a recommendation, which I think as family med docs, we see a lot in our young pediatric patients with asthma, but it's not really something that I've come across routinely for our older adults with COPD. And then, of course, managing comorbidities. It's not uncommon for our patients with COPD to have high blood pressure, high cholesterol, heart failure. And so obviously all of those can also increase risk of breathlessness, chest pain, things that are also symptoms of COPD. So then kind of going step by step through those management recommendations, first thinking about smoking cessation. There are obviously some pharmacotherapies available for smoking cessation listed here. We have Chantix, nortriptyline, Wellbutrin, and nicotine replacement therapies. This becomes a point the kind of first entrance point that we can start to think about using clinical pharmacy to potentially talk with patient about risks and benefits of some of these medications. And then there are also a lot of non-pharmacologic strategies for smoking cessation. There are formalized programs, counselors that specialize in smoking cessation, and then truly the GOLD group recommends that at every single touch point with a patient, we discuss smoking. You know, you don't have to be a broken record about smoking cessation, but really just checking and saying, how much are you smoking? How can we support you in your efforts to cut back or quit? And then also a great place to allow for virtual follow-up and utilize other support staff in clinics is to, you know, if you have a COPD follow-up in person, few weeks later, having MAs or nursing call in to check in on, you know, maybe at that visit we did some nicotine replacement. How is that going? You know, when should we make your follow-up? How can we continue to support you? Because truly, as we always talk about in primary care, a uh, ounce of prevention is worth a pound of cure. And so that is such a huge part of COPD management. Then, obviously, with lung disease, we worry about viral lung infections. So, making sure that vaccinations are up to date. This is, again, a crucial role for support staff in primary care to check in on and make sure we're up to date on the most like the latest recommended CDC vaccine schedule for patients, older adults and people with COPD. Generally, over the years, it's included influenza, more recently COVID, pneumococcal, more recently RSV, pertussis, and herpes zoster vaccinations. And then we think about rehabilitation, education, and self-management. So for individuals with COPD that have high symptom burden or at an increased risk of exacerbation, there is decent evidence to say that pulmonary rehabilitation for at least 6 to 8 weeks duration can be hugely important for these patients. You know, sometimes when we think about that availability of programs in rural settings or in lower resource settings, that can be a little difficult, but it has been proven to be helpful for people with that high symptom burden and increased risk of exacerbation. Um, Also, generally, any degree of physical activity, especially supervised physical activity, is helpful for really all of our patients, but then can be helpful in people with COPD, just continuing to keep good lung reserve. Um, and then this is a point where I would say, um, usually if you have a community health worker in your clinic system, um, they're a great resource to help connect patients with based on their current insurance or access. Do they have community options for supervised exercise or getting connected with a Y, just making sure they're aware of the resources that can help them get physically active. Then doing either group or individualized education about kind of what is COPD, what are the things that trigger and exacerbate and worsen your lung function, and then um, written action plans, as I mentioned. Some people will really encourage patients to have a written out green, yellow, and red zones to recognize and manage symptoms, and ideally kind of intervene early on exacerbations, reducing the risk of hospitalization. And so something that can be adapted based on clinic systems, and something that I would plan to actually do more in my own clinic based on what I was reading. Then lastly, our behavioral health support and providers, breathing retraining to help with the symptom of breathlessness and anxiety around COPD symptoms can be hugely important to make sure that you know, the medications are doing what they need, but also kind of building that patient's own autonomy and confidence in managing their symptoms and their COPD. All right. So then we kind of will delve deeper into pharmacological management of COPD. Generally, this is tailored based on level of symptoms and risk for exacerbation. And as therapies are escalated or de-escalated based on, you know, perceived symptoms, exercise ability, and continued occurrence of exacerbations while on their usual maintenance therapies. Um, Interestingly, the GOLD guidelines state that truly for that initial start of inhaler therapies, there's not yet great randomized control trials for that first step, but they do base like follow-up and remaining of recommendations on both randomized control trials as well as expert opinion. So it's always like with that grain of salt. And so updating our COPD severity assessment tools. On the left here, I have the ABCD assessment tool, which had been used, the model that Gold used from 2011 to 2022. And as we can see, you know, starting with diagnosis based on confirmed spirometry, assessing the FEV1, those two are the same between that prior and the updated version of this assessment tool, but really the difference comes in being 3 groups rather than the 4. And so we'll go into this a little more. Previously, when there was the A, B, C, and D groups for initial pharmacotherapy, you know, at baseline, it was recommended that if you've had no exacerbations or one moderate exacerbation that was not requiring hospital stay, and that your symptom burden was rather low, then a bronchodilator would be appropriate. And this can either be a short-acting bronchodilator or a long-acting bronchodilator. And you'll see in Group A, based on this updated version, that is the same. Then for Group B, previously it was recommended either some type of long-acting bronchodilator, whether that was a LABA or a LAMA. And now the first change that you'll see is that Group B is actually recommended to have combined dual therapy of a LABA plus a LAMA. And then in Group C, it was preferentially using a long-acting muscarinic agonist. And then Group D was either a LAMA plus a LABA, or a LABA plus an ICS. And this is also the big change where they've grouped pretty much anyone who's had greater than 2 moderate exacerbations or a hospitalization for a COPD exacerbation, as they should at baseline be on this dual therapy of a LABA plus a LAMA, and then consideration of triple therapy with a LAMA, LABA, and inhaled corticosteroid based on the eosinophil count as kind of a proxy of is there concurrent inflammatory changes or kind of more on the asthma spectrum of things. And so kind of delving deeper into this initial pharmacotherapy, we will highlight that I'll go through some data that shows why the Group B and Group E changes were made. But interestingly, here, I think, okay, there we go. So the research behind these recommendations, there were 2 prior trials called the TORCH and SUMMIT trials that compared the efficacy of a LABA plus ICS therapy at reducing all-cause mortality compared to monotherapy, meaning just a bronchodilator, just a LABA/LAMA, or placebo. And in these two trials, neither were able to show statistical or clinical significance of the LABA and ICS therapy reducing all-cause mortality. And so it was kind of this initial schema change of maybe the LABA plus the ICS for COPD in particular is not quite as effective as we had previously thought. Then the EMAX trial in 2019, which stands for Early Maximization Trial, compared the effectiveness of a dual versus mono bronchodilator therapy in symptomatic patients at a low risk of exacerbation and not already on an inhaled corticosteroid. What they found in this is the number needed to treat is 5 patients if you're on a combined LABA plus LAMA in order to prevent one additional, what they called clinically important deterioration. And so, and this was at a 24-week mark. It was a 52-week study, and they kind of marked things halfway through. But generally what they said is, if you have this dual therapy as opposed to the monotherapy, they noticed slightly improved FEV1 that they measured at the 24-week mark, improved symptoms, including breathlessness, daily respiratory symptoms, rescue medication use. And then what they defined as the clinically important deterioration was either, an outpatient or hospitalization for an exacerbation. And that they were starting to notice that kind of doing dual therapy early was actually helping to prevent a lot of these adverse outcomes. Next, the IMPACT trial believe in 2020, which stands for the Informing the Pathway of COPD Treatment, was a randomized controlled trial studying the efficacy and safety of a once daily single inhaler that included a LAMA, LABA, and ICS compared to the dual therapy, which is the LAMA plus LABA, in patients with symptomatic COPD and history of exacerbations. And so you can kind of see as this research unfolded, in the EMAX, they were looking at someone who had not, were symptomatic, but had not had previous exacerbations and were not already on inhaled corticosteroids, whereas the IMPACT takes that next step to say, they have had history of exacerbations and they are either being treated with that triple inhaler therapy versus this dual inhaler therapy. And what that study found is that it reduced the annual rate of moderate to severe exacerbations. There were lower number of hospitalizations in people with that were on the triple inhaler therapy. And what they a statistical significance in the decreased amount of all-cause mortality. The approximate number needed to treat for this study was about 3 to 4 patients treated with triple therapy would prevent one moderate to severe exacerbation. And then lastly, the ETHOS trial demonstrated that single inhaler triple therapy with varying doses of the inhaled glucocorticoid component may have lowered the rates of all-cause mortality in patients with moderate to severe COPD with that history of exacerbation. But interestingly, in this study, the number needed to treat for to prevent one additional death over the course of a year was 200. And for every 53 patient number needed to harm, like for every 53 patients that were treated with triple therapy instead of dual bronchodilator therapy, there was one additional case of pneumonia. And so they had started to create further clinical questions about what is then the risk of inhaled corticosteroids in COPD management, especially in terms of developing pneumonia. And so then, so that's kind of the updates to the initial therapy for COPD that has just been diagnosed in the outpatient setting, and just highlighting those changes that the GOLD guidelines started to recommend in 2023. Then, obviously, this is a chronic disease that we see routinely in follow-up. And so after being started on their initial therapy, you do want to follow up pretty regularly and review symptoms, whether this includes breathlessness, dyspnea, cough, and then also their history of exacerbations on the maintenance therapy that you have thus started. The thing that I think is another place where support staff can be integral in helping make sure these patients are getting most appropriate treatment for their care is, again, roping in clinical pharmacy to say, especially in these early visits, should the patient have any questions about how do I use my inhaler, what is the most effective technique, and bringing in their inhalers to say, this is how I take it, and this is how I inhale it, to then make sure that we are not escalating therapy just due to incorrect usage or confusion about how often or how exactly to use the inhalers. And then making sure that we've optimized or at least are continuing to check in on non-pharmacologic approaches. This includes that self-education piece, the written action plan, pulmonary rehab, and of course, smoking cessation. And then based on how they are doing at follow-up, adjusting therapies to either escalate if they are having worsened symptoms or having exacerbations despite using their controller inhalers appropriately, and adhering to that therapy, versus de-escalating if they are actually doing better than expected, and we can do kind of less is more. And then there are some changes that can be made based on inhaler device and the patient's ability to physically use the inhaler, which is another place that clinical pharmacy can be so integral in understanding what is makes the most sense for each individual patient. And interestingly, GOLD guidelines do recommend annual spirometry for close management and monitoring of COPD, which is certainly something that my patients have not routinely done. And so now it's also another thing of, especially in our family medicine practices and in more rural settings, getting more comfortable with using in-office spirometry to potentially have that more regular follow-up to guide treatment and make sure that patients are not worsening on their maintenance therapy. So then in the event that someone is having worsened shortness of breath or they have had exacerbations on their maintenance therapy, the GOLD guidelines provide this schematic to say, if they were if they're feeling short of breath and they are on a single bronchodilator therapy, that can be a good reason to escalate to dual bronchodilator therapy. Also making sure that other causes of their shortness of breath are addressed. And then in the event of following up after exacerbations, It provides guidance on based on eosinophil count, if it would be reasonable to do the dual bronchodilator therapy or to add the inhaled corticosteroid therapy. In general, if the blood eosinophils are over 300, then it is considered a reasonable thing to do. Or if they've had a exacerbation on the dual therapy and their eosinophils are over 100, then that's a reasonable thing to add the inhaled corticosteroid. And then I will briefly talk about these two of these bottom medications that I don't think are as common for us to prescribe in our primary care clinics, but are emerging treatments for people with severe to very severe COPD that are having recurrent exacerbations on their maintenance inhaler therapy. So the first of those being roflumilast, which is a phosphodiesterase 4 inhibitor. The way that this is supposed to work is reducing inflammation by inhibiting the breakdown of intracellular AMP. And it is meant to decrease the likelihood of moderate to severe exacerbations, specifically those treated with glucocorticoids and patients with chronic bronchitis in the severe to very severe COPD. Then the other that was mentioned was dupilumab, which is a monoclonal antibody against interleukin 4 and 13. This is something that has historically been a treatment option for asthma, and I think there is emerging research about its application within COPD as well. And the way that this is the proposed mechanism of action of this is decreasing eosinophilic airway inflammation. And thus, we know that that is present in people with asthma. And then if we look back at our prior follow-up treatment, this is saying you're on triple therapy and your eosinophils are still over 300, then it may make sense to add that monoclonal antibody to try to help decrease the eosinophilic airway inflammation. And as I mentioned, there are, further discussion about oxygen therapy and when it's indicated in COPD, further discussion about surgical or bronchoscopic interventions. And while oxygen therapy is certainly within our wheelhouse as primary care providers, those other two are less so. And for time, I cut the oxygen therapy out, but would be happy to answer questions on that. So then we get back to our case. We're seeing our 70-year-old gentleman who was recently treated for an outpatient COPD exacerbation. This is his history, just as a reminder. And so in our visit, we ask him how he's doing symptom-wise. And so this is the MRC dyspnea scale that you can use. Other people have different ways of assessing dyspnea and symptoms, but for our patient, he marked that, he is someone who cares for his wife and he does all the cooking, cleaning around the house, and he often has to sit down, stop, pause in order to catch his breath, even doing his normal activities. And that was the case before this exacerbation, and it's gotten worse and more frequent needs to stop and rest since he had this outpatient exacerbation. Then he also filled out the CAT assessment to see, he does, let's see if my annotations work. He does cough, relatively frequently, not noticing much phlegm since the exacerbation has gotten better. Chest isn't too tight. He does feel that when he walks up the stairs in his house, he's pretty breathless. He is limited in that his activities, as we talked about, and he's still confident in his ability he doesn't really sleep all that much. His wife says maybe a few times a week she'll notice his snoring. And then he has moderate energy. And so that brings him to a score of 17 for his symptoms on this CAT assessment. And so in thinking about next steps for our patient, let me get that. So as I mentioned, he is someone who has a lot of areas that we could optimize and try to help both from a pharmacological and a non-pharmacological treatment strategy standpoint. So he is someone who's self-identified that tobacco use is a form of stress relief for him. He is more stressed about his wife being sick, and so he's increased his tobacco use. Um, Sometimes it can be helpful to make that connection um, and say, how can I support you, whether it's behavioral health referral, nicotine replacement. Do you just want to do a follow-up with me? And we talk specifically about smoking. Um, you know, he is great and is up to date on his vaccinations, but we would make sure that his based on the CDC's guidelines, has he gotten his RSV? Because he is an individual over 60 with a comorbid condition. And then he would be someone that if the resources were available in our community, we could offer pulmonary rehabilitation because it's really in those groups B and E that it has been shown to be, 6 to 8 weeks of that rehab can be beneficial. Um, and then, as I mentioned, the behavioral health referral. And then thinking specifically about his medications, I had mentioned that he is on Symbicort, which is a long-acting beta agonist plus an inhaled corticosteroid. And I'll highlight why, but in the coming slides, but he is someone we would probably recommend instead change to a dual bronchodilator, LAMA-LABA therapy, and consider keeping the inhaled corticosteroid present depending on his eosinophil count. And so there's a specific section talking about management of patients that are currently on things like Symbicort, this LABA ICS combo, because it was previously a part of the stepwise approach for someone with COPD. And so it's not uncommon for our patients to be on this therapy. So as we'll just follow the diagram that for someone that's currently on a LABA and ICS, if they are not having exacerbations, they have responded well to this treatment and they're not symptomatic, it is reasonable to continue on with that treatment. If instead they are symptomatic, it would be reasonable to think about changing them to that triple therapy, the LABA, LAMA, and ICS. And then if they're actively having exacerbations, as our patient did, it would be at the very least recommended to change to a dual bronchodilator therapy, that LABA-LAMA combo, and then the consideration of checking a eosinophil count to kind of help guide, is it empirically a good idea to keep them on the ICS, or is it reasonable to potentially retrial therapy with just the dual bronchodilator inhalers? All right, and then for our patient then, he is agreeable to someone calling him within the next week to follow up and check in on his tobacco use. He does not feel ready to start a medication for tobacco cessation, but does feel like he needs to cut down. As I mentioned, he's up to date on his vaccinations. He's open to a behavioral health referral to discuss caregiver stress, and he had never heard of breathing retraining. And so he is interested in open to learning more about that. And then he was on board with changing his Symbicort to Anora ellipta. So that's that changing the LABA and ICS to a dual bronchodilator therapy, which is the LAMA-LABA. And so that is actually all I have. I went a little faster than I had in practice, so we have a little extra time for questions.
Thank you, Dr. Farina. For our participants, feel free to put your questions in the chat or just unmute yourself and fire away.
Hmm. And I will say, the guidelines themselves are like 100 and some pages long, but Gold actually puts out a pocket guide that summarizes the updates on these recommendations, and so super helpful place to go for the especially for the inhaler management part of things. But it was good learning for me to say all the other places other than just medications that we can help folks with COPD.
Thank you again. And just a reminder, the slides and a recording will be available on the website. Take care, everyone. Have a great rest of your day.